In the second phase, we de-emphasized the food because there were less food and it was very difficult to get it. And the World Food Program was not willing to buy food was available in the capital because there were traders who had food they hadn't been able to sell. So they were willing to sell the food, but the World Food Program, which had received money from Sweden, were not willing to buy food locally to distribute to the population, in fact, of that being a needed population. There were many reasons, like they couldn't get their logo on the sacks, so we couldn't buy this. Eventually got money from the EU. They didn't care about the logo, so we could buy with EU money. We could distribute rice to the population again. But I think in the last phase, when people went back to the capital, we emphasized things like soap, so we distributed soap for hygiene. We provided treatment of malnourished children. We provided vitamin A distribution, bed nets and impregnation, and we finally got TB drugs. And so this is within the study area. For the whole city of Bissau, we provided clinical consultations to all the health centers, support for the hospital, measles vaccination on an ongoing basis, and bed nets to mothers of children less than 2 years. And then we had a big measles epidemic, and we had a national meningitis epidemic, where we, in collaboration with Médecins Sans Frontières, provided the services. After the war, we had house construction. I'm not going to talk about that. What kind of data do you get in these situations, and should we analyze it? We have tried to analyze both, sort of searching for what are risk factors for mortality in an emergent situation. And I admit we clearly had unique data in the sense that we had prior data on this population, and therefore we could do what I had called here before-after studies, where you see what does this factor mean in a normal situation, and what does it mean in an emergency situation. We have also done sort of surveys like the first one I explained about, and I'll come back to some other methodologies and we can discuss these methodological issues. We also have a lot of data we simply haven't had the resources to analyze. There's still much more we could do with our data. We have not had the resources to do that. But I'll present a few of the results here. When the war starts, everyone runs away, and things like the TB treatment, it stops. There's no one to distribute the drugs. People, the TB patient had to run away. And you can see here, we took the TB cohort, the people who were under treatment at the time of the conflict, and saw what happened to them in terms of mortality during the normal treatment period, which is 6 months. And we compared with what had happened to a similar group from the year previously. And you will see that if you compare the mortality ratio of those who were in treatment in the war period and in the peace cohort, you had 3 times higher mortality. And if you compare those who had just completed treatment, there was essentially no difference between the previous year and those in this year. So TB patient would clearly be a high-risk group. No one thought about bringing in TB drugs in this situation. You may also note that those who were most affected in the TB cohort were those who had HIV infection. So it's really the HIV-infected people who were hit by sort of the absence of the drugs. And we could also show sort of similar things for, Bissau is the center of the second HIV virus, which is much less severe than HIV-1. It's called HIV-2. It's a similar type of virus and can give the same results, but doesn't always. It's not always invariably fatal. You will see in the population over 50, we have a cohort here that we have followed for many years, it's roughly 15% of the population who are infected with this virus. In the year between, for this 10 years where we have followed this cohort, these people have roughly 70% higher mortality than HIV uninfected. During the war, they got nearly 6 times higher mortality. So they are much less, the weak groups are much less resistant in a time of conflict. They will get much more hit by this. At that time, there were no HIV drugs in the population. HIV drugs were not available, but if you have another drug conflict in a situation with HIV treatment, that is a group which one should think about because they are likely to be hit very strongly by the sort of disintegration of the healthcare system. Another sort of example of before and after comparison is if you take the age in between 9 and 20 months, we compared the mortality of children who were weaned and children who were breastfed. And you should know that the weaned children would tend to be better than the breastfed. There is sort of a negative selection bias in going on with being breastfed. It's not the bad children who were weaned. You see, in the war situation, controlling for age here, those who were weaned had nearly 6 times higher mortality than those who had been breastfed. If you take in the normal situation here, in the 2 years before the war, there were virtually no difference. So breastfeeding is probably very essential in this situation where you're dealing with a lot of infections. And if you, I don't know whether it's possible, it might have been possible to encourage mothers to start re-breastfeeding. That would have been, it's biologically possible, whether it would have been sort of, I think it would have been socially acceptable as well in this situation. We didn't do it because this was just analyzed afterward. But something that one might think about in other situations. Something very strange happened at the hospital. We have been following the pediatric ward. And you will see during this year with the war, this is the case fatality of the hospitalized patients. And we see normally it has been sort of between 12 and 15% of the children die at the hospital, you know, all causes combined. But during the war, mortality dropped 42%. There was a 42% reduction in mortality. We have checked everything we could find out about. There's no indication that this is due to selection bias. It's not better children who were hospitalized during the war. We think this is a genuine effect of something happened. And you'll see it's much better for children without mothers without schooling than it was for mothers with schooling. So among children of uneducated mother, there was a 73% reduction in the mortality. Why would that be? We also tested, I'm coming back to that. We also tested something, and I think in the working group we had a discussion earlier about what kind of study can you do in a situation. Can you do a randomized trial? That would be very difficult. We couldn't get access in the ethical committee, etc. Something you can sometimes do is what has been called a stepwise design. Sometimes you don't have the resources to treat everyone at the same time. You're doing it gradually. And if you do that, you can sort of say you start with an intervention here. We started with vitamin A, and we measured, it took 3 months to introduce that, and then you can compare those who are getting the intervention in relation to those who are not getting the intervention. That looked positive, but it's a small study. But I think that's the kind of thing which could be done in conflict situation where you cannot treat everyone at the same time. You can get an idea of which things are actually important to do and which things doesn't work. And I think this is important because there is sort of there is a total, in my view, very severe miscomprehension of which things work and which things doesn't work in this kind of situation. Just to give you a sort of picture, during the war we did measles vaccination campaigns in December, and we did general meningitis vaccination campaign. Yeah.